Good evening, everyone, and welcome to our September edition of Checking In on You. My name is Dr. Sandy Arthur, and I would be guiding you through this program this evening. Welcome. To start us off, we're going to have a presentation that is going to be done by Miss Melissa Brayton, who is one of our quality control officers working with the promotion team at this point in time. And she is going to present on how to access services within the Southwest Regional Health Authority. So I will hand you over to Miss Melissa Brayton at this time as she takes you through this part of our program.
Good afternoon, everyone. My name is Melissa Brayton, as Dr. Sandy Arthur would have stated. I am a quality control officer currently within the primary healthcare settings, so somewhat, as well as the health promotion team. And tonight I'll be presenting to you all on how to access service, primarily primary care services. So I'm just going to share my screen so you guys can see the presentation. Right. So before I get into it, I'll just share with you guys a little overview of the Southwest Regional Health. And we at the SWRHA, or the Southwest Regional Health Authority, is the largest regional health authority which serves a population of more than 600,000 persons. The SWRHA comprises of 31 primary healthcare facilities, 2 extended care centers, 3 district health facilities, and within our district health facilities, we also have primary healthcare centers in them. We have 2 hospitals, which is the San Fernando General and Teaching Hospital, as well as the Point Fortin Hospital, and 1 rehabilitative center. So who are we and what are we about? Our vision at the Southwest Regional Health is to become a leading provider of compassionate, cost-effective, premium quality care service to the people of the Southwest region. Our mission is that we are in the business of promoting wellness and providing cost-effective, customer-focused healthcare to the people of the Southwest region within the guidelines of the national policy, while ensuring our staff is a productive and rewarding environment. So what is primary healthcare? According to the WHO and UNICEF, primary healthcare is a whole of society approach to health that aims at ensuring the highest possible level of health and well-being and their equitable distribution by focusing on people's needs and as early as possible along the continuum from health promotion, which is who we are, Dr. Sandy, myself, and Nurse Kelly Jeffrey, and disease prevention to treatment, rehabilitation, and palliative care, and as close as possible, as close and as feasible to people's everyday environments. So primary healthcare is basically not just me, you, or Dr. Sandy Arthur, or Liz Kelly, or anybody else that is involved. It's a whole of society approach. So why is primary healthcare important to you, our listeners, this afternoon? To help spot health problems before they become serious. It is the best way to manage existing health conditions that you may have. It's for early health intervention. Primary healthcare is basically the doorkeepers or the gatekeepers to access non-emergent healthcare. Primary healthcare also provides services for each member of the family. So it's not just for auntie and uncle, but it starts from as early as toddler. Well, actually before you are born, right? Because primary healthcare services within the SWRHA include health office days. And what is health office days? So if you're not attached to a primary healthcare center, or as we would call it, a health center, on any one of these days, you can walk in and register to become a member of a primary healthcare center. We have chronic disease. Tonight we are discussing chronic illness. So if you happen to fall within part of this presentation, Chronic disease clinic is something that you can attend if your numbers, knowing your numbers, that's going to come on later on, but knowing your numbers is important as well in order for you to join chronic disease clinic. We have antenatal and postnatal clinic. We have child health clinic within the primary healthcare services, family planning, which is for both male and female, not just for females. We have same-day HIV testing, which is at selected health centers. We have child wellness centers, which is also at selected health centers. We have dressings, which is not just if you come out from, let's say, surgery, or you would have had a cut or a bruise or an injury, you can go to the health center and they would actually dress the injury, they actually teach you how to get it done for yourself as well. We have adult immunization, so you can check your immunization card, and if your vaccination is not up to date, and this is not just the COVID-19 vaccination, but we are also talking about tetanus injection, your yellow fever, HPV vaccines. You can check your immunization card, or you can go to your local health center and a nurse would inform you or advise you on what vaccines you need to take or be updated with. We have pharmacy services, and our pharmacy services, and let me point this out very clearly, our pharmacy services, our prescriptions are only filled by prescriptions issued by the SWRHA. Private prescriptions will not be facilitated at the SWRHA sites that have pharmacy services. We also have specialist services within the primary care services, and they are SPOG clinic, which is a specialist obstetrics clinic. So if someone is pregnant and they require special antenatal care, we have a specialist clinic, and this is done by a referral system. Same thing for our mental health services. They are done by referrals, so you can't just walk in and access that service. You have to be referred in order to attend these clinics. We have retinopathy screening, smoking cessation. So if you're a smoker tonight and you're logged in and you are desirous of stopping or quitting smoking, there is a clinic for that to help you and to sensitize you on how to follow through with the steps, not just to stop, but to also advise persons to not engage in or to begin smoking. We have change of catheter clinic, which is not just to change your catheter, but to also guide you and to teach you how to manage the apparatus while it's on you, if you ever were to have a catheter within your system. We have child development clinic, and this is so a very touchy point for me tonight, because in recent times I've seen so many parents asking about developmental clinic for their kids. Not that anything is wrong with them, but they are seeking guidance on how to go about, their child getting assistance with either trauma or anything that the child is going through right now. Not because the parent is doing something wrong, but every child is unique. And there are programs within our health centers, not all of them, but this actual clinic, there is a referral system as well. So I encourage you, if you are a parent logged on tonight and you have issues with your kid, and like I said, it's not because you are doing anything wrong, but you are just needing guidance as how to bring your child and how to deal with the trauma effects that the child may have been through or going through, there's something called the Child Development Clinic, and you can just visit your local health center on the child clinic day, and they would write a referral for you. So when to access services within the primary healthcare service? Either as a routine visit once or twice a year for appropriate screening and general review. If you have any medical health issue that does not require a visit to the emergency department. So when do I visit the emergency department? If you have or experiencing severe chest pain, and please don't call it a gas pain, we are not telling you. A lot of people think that, oh my God, it's just a gas pain. I probably didn't eat properly today. I'm advising you to not take that very lightly and visit the nearest emergency department. If you have severe abdominal pain, if you were in a motor vehicular accident, if you experience a gunshot wound or a chop wound, if the person or yourself, well, I don't expect you to call, but near drowning experiences, allergic reactions, asthma attacks, if you would have experienced a fall or a blow to the head, or the ingestion of toxic substances. And this list is not exhausted, sorry, but you can also visit the Ministry of Health website, and that's where you can type in accessing public health care, and there's a comprehensive list of primary and secondary care services and when to visit the emergency departments and primary healthcare services to access primary healthcare services, sorry. I think I was stuck. So I think my presentation is stuck. But how do you access primary healthcare services? And you can access primary healthcare services by walking into any one of our 31 primary healthcare centers during the hours of 8 a.m. to 4 p.m. Monday to Friday. And I repeat, you can access primary healthcare services by walking into any one of our 31 primary healthcare centers during the hours of 8 a.m. to 4 p.m. Monday to Friday. Or you can also call for further information, because I know some of you may not know when some of these services at the primary healthcare sites. You can call our customer service center at 877-9742. That is 87 SWRHA or 877-9742. And this number is a toll-free number. If you don't have money on your phone and you need to call SWRHA to find out something, or to lodge a complaint, or to give a commendation based on our presentation tonight, you can call 877-9742, and that number is toll-free. You can also email our customer service center at customer service, that is CUSTOMERSERVICE at SWRHA.co.tt. Or you can visit any one of our SWRHA social media pages, which is Facebook and Instagram, to follow up on what's happening, what we are doing, where next we are visiting, when we are having our next live program. You can also visit our YouTube page, or our YouTube site, and that is SWRHA on YouTube. And that's where we have a lot more presentations, including tonight's presentation. Our team at the Corporate Communication Department uploads every time we have a presentation on any one of our talks that we are having. We upload our information on the YouTube page. So if you would have missed it, or you want to get back more information, you can visit the YouTube site. And once again, if you want to access any of our services and you need further information on it, you can call our quality customer service call center at 877-9742. And that's it tonight for how to access services, primary healthcare. I hope you guys enjoy the rest of your presentation. Back to you, Dr. Arthur.
Thank you very much, Ms. Brayton, for that comprehensive overview of how to access services. Today's forum, we're looking at living with chronic diseases, and we have the tagline called Power Through Collective Action. For those of you who follow health observances, you would know that we would have celebrated Caribbean Wellness Day this month on the 10th of September. It's celebrated every second Saturday of the month of September every year, and it's a Caribbean-wide initiative. And that's their tagline, Power Through Collective Action, because we realize as healthcare providers that unless we work together to combat some of these problems and challenges, we're not going to be successful. I would like to take a moment to introduce to you our expert panel this evening, a group of lovely ladies. And we're going to start with Mrs. Natisha Kerr-Lambert. She is a registered dietitian, certified baby-friendly hospital initiative trainer, and the regional manager of nutrition and dietetics at the Southwest Regional Health Authority. She has a BSc in human ecology with specialty in nutrition and dietetics, a diploma in institutional and community nutrition and dietetics, and a postgraduate specialty in sports nutrition. Ms. Lambert is currently a member of the Trinidad and Tobago's Nutritionists and Dietitians Board, where she holds the position of representative to the Council of Professionals Related to Medicine. Other memberships would include the Nutrition Standards Committee of the Ministry of Health, Revenue Generation and Cost Reduction Committee, and the Health Promotion Committee, both of the SWRHA. She enjoys outdoor activities like hiking, and on the other hand, likes a quiet corner to read. Mrs. Kerr-Lambert, thank you for joining us.
Thank
Up
you.
next, we have Mrs. Rayanne Sami, and she is the Senior Medical Social Worker, acting Head of Department of the Southwest Regional Health Authority. She has been employed in the healthcare industry as a medical social worker professional for almost 30 years, both as a clinician and an administrator. Her practice has spanned health settings across Trinidad, both at the institutional and primary levels of health, working with diverse clients, helping them to cope and live with chronic disease and other health and psychosocial challenges. She is passionate about promoting the role of the medical social worker as a specialist within interdisciplinary teams towards the achievement of holistic patient care. She has also served on several SWRHA board and Ministry of Health committees, including medical bioethics, medical aid, and recently appointed to the Ministry of Health Clinical Governance and Research Ethics Committee. She is pleased to represent the Medical Social Work Department tonight and to share experiences and perspective in this multidisciplinary panel. She also likes to sing and enjoys outdoor activities. Welcome, Mrs. Sami. Good to have you. Our next panelist, and we just remember to unmute as well. Our next panelist is Miss Marcia Guevara. She is a practicing registered nurse with over 13 years of experience. 5 years ago, she became a Caribbean certified diabetes educator and is currently attached to the Patient Education and Counseling Center of the Community Liaison Unit at the Southwest Regional Health Authority. Her hobbies also include singing and dancing. So we welcome these three ladies tonight and we thank them for joining us. As I indicated earlier, my name is Dr. Sandy Arthur. I am a primary care physician hailing from the beautiful, wonderful island of Barbados. And I have a passion for primary health care and working with community groups and relevant team members to ensure that persons achieve the best possible health that they can for themselves and their families. So without further ado, we get into our discussion this evening. Please be reminded or be informed that you can submit questions in the chat box and we will address them for you. So you can just go ahead at any point in time during today's proceedings and type them in. We welcome back those who would have joined us in previous presentations as well. Good to see you again. Chronic diseases, also referred to as non-communicable diseases, have reached epidemic proportions in the Western Hemisphere, including in Trinidad and Tobago. And within the last 2 years, we would have learned so much about epidemics and pandemics. But long before we had anything to consider like a COVID pandemic, we were battling with the epidemic of chronic diseases. Unfortunately, they cause over 60% of the deaths in Trinidad and Tobago annually. And they cause many other complications that reduce the quality of life for persons living with these conditions. So that we're all on the same page, chronic diseases are those conditions that are not mainly caused by an acute infection and result in long-term health challenges requiring long-term treatment and care. So a chronic disease is oftentimes a disease that we are unable to cure, but through control, we can manage them and hopefully improve quality of life and prevent or delay onset of complications. So Marcia, in your role as a patient educator, what conditions do persons usually come to you for education and counseling? Just in your day-to-day experience. I've seen that Marcia is not with us at this point in time, so I will ask Natisha, or registered dietitian, what are the common conditions that persons usually come to you for?
Well, when we look at the referrals, we may see cancers, we may see some form of cardiovascular diseases, we may see, well, the most popular diabetes. You may see lung diseases, um, but you may also see mental health. And mental health illnesses are not very popular. Most people would not classify it as being a non communicable disease, but it is. So we have those conditions that we would normally see on referrals. And to add to that, most popularly, especially in the community setting, we would see metabolic syndrome written on the referrals. And it's really like a group of diseases for the persons who don't understand what it may mean. But it's a group of diseases that may increase your risk of developing coronary heart disease, maybe increasing your risk of developing diabetes. So when your physician sees hypertension plus diabetes, he may refer you to the dietitian because he's seeing an increased risk. And instead of putting those, you may see him put metabolic syndrome, or you may see hypertension and high cholesterol, high triglycerides, and those combinations do increase your risk. So you would see metabolic syndrome written on it.
Thank you. I'm very happy that you mentioned or that you highlighted mental health conditions and mental health illnesses because oftentimes that's something that we don't often highlight as a chronic disease, and it is. And nutrition plays a very big role in managing that as well. So I'm glad you mentioned that, and we'll get into some more specifics about that as we go along. But Rayanne, in your work as a medical social worker and in your field, what are the common things that you see in terms of chronic illnesses? Just remember to unmute. We're still not hearing. Just remember to unmute. Yeah. She seems to be having a challenge. And I see that Marcia joined us back. So I'll let Marcia share in and weigh in at this point in time. And we're just talking about common conditions that persons may come to you for, Marcia, in your education and counseling center. What are the common things that you often see persons come to you for counseling on in your
Hey,
field?
good night. Are you hearing me?
Yes, I am.
And are you seeing me as well?
Yes, we are.
Okay, so what I would say, the most common conditions that we would see at our department would be patients who suffer from either diabetes or high blood pressure. Those would be the most common conditions we would see on a day-to-day basis.
And I think that that is something that we are very concerned about in primary care, especially, and in the secondary setting of healthcare, because it seems that almost every other person you come into contact with has a complaint of hypertension or diabetes or both, or they know someone who suffers from one or the two of these illnesses. Um, so thank you for sharing that with us. And for highlighting those two especially because I think that those are the ones that persons are most aware of and they think of first and foremost. I'm just going to touch back with Mrs. Sammy at this time. Are you with us? Okay, so as she gets that sorted out, we're just going to continue and discuss a little further. So, as a healthcare provider, because we all work in healthcare in different sections and in different fields, what is your biggest concern about NCDs and the impact that they have on people and families that you come into contact with? And I'll start with Mrs. Lambert.
So my concern where NCDs are really discussed is a bit odd, because my concern is the information that is given to persons when they are diagnosed with these NCDs, any one of them. Simply because even in our culture, the minute you mention to somebody that you are diagnosed with any condition, automatically we know what happens. They start giving you information. And sometimes that information comes from people that are very close to us, our relatives, your neighbors, your co-workers. And we are not sure about the source of the information, the accuracy of the information, or the application of that information to you as an individual. So it's not that the information may be wrong, but it just may not be applicable to you. So that going back to the theme of power through collective action, you find that I am very concerned for persons who are diagnosed. And if we as the professionals, we are not working collectively, then we may find instances where one professional may give one sort of advice, another different perspective from that same condition, and then we have conflict developing. So for me, the information that they get is critical, because that is what determines their success in managing it, and in some cases, controlling it to the point where it's as if they don't have the conditions.
I like what you stress at the end, controlling it as if they don't have the
As
conditions.
if,
Because I think,
yes, as
yeah,
if.
that is like one of the biggest things that persons would usually say, well, now my life is over, I can't live life. And there's
Correct.
still so many things that you can do. You can have and enjoy day-to-day things just like other persons. It's just that you're more mindful about certain
That's
things.
right.
So I like what you stressed at the end there.
That's right.
What about you, Marcia? What is your biggest concern about persons who you meet with day to day as it relates to, their NCDs?
Well, Dr. Sandy, what I would say would be one of the biggest challenge, I would say would be family support. Now, a lot of the clients don't have that at home. So you find that they would be a bit depressed. And of course, with depression, no, I'm not a psychologist to diagnose them as having depression, but they would be, of course, a bit down from my perspective. And I think with that, generally, it does not allow them to manage as well as they possibly can. So what we try to do is encourage the family to be there for the clients, because of course, if they have a chronic disease, which means it is lifelong, so that support is going to be an encouragement for them to manage the condition going forward a bit better.
Okay. And I saw that Mrs. Sammy rejoined us. I'm going to give her the opportunity to share with us. We're just catching up on one, the concerns that you have in your field of work for persons with NCDs, and you can also share with us a bit about, um, you know, the conditions that you commonly seen in your field.
Right, good night, and sorry again, there seemed to be some difficulty I was having, so I left the meeting and rejoined, so I do apologize.
No
Um,
problem.
all right, so you're hearing me clearly now, right?
Very much so.
Yes. Okay, so as medical social workers, both at the primary healthcare level and at the institutional level, we see varying NCDs being presented when clients are referred to our department for assistance for psychosocial support. So we have persons being referred for cancers, with hypertension, diabetes, renal disease, chronic renal failure, strokes, who need supportive care, etc., as well as with autoimmune diseases. We have been seeing a lot of that coming in, and the stress factors related to those diseases. And of course, there are always psychosocial issues that need to be addressed with patients who have conditions that require long-term management. Yes, and we have been seeing a lot of cardiac disease as well, referrals for diagnostic tests and procedures for patients who are unable to afford, etc., so that doctors can further manage these patients.
Okay, thank you very much. And I think we all have and share similar concerns for the persons we come into contact with. I think one of my biggest worries and concerns are just the sheer number of persons who are now having to access care for one chronic disease or the other. And oftentimes now it's not just persons, you used to think middle-aged person coming in to access care, but now we're seeing persons younger and younger and younger presenting. And oftentimes it's not even what you expect them to present with you for. So in my training as a physician, we would have learned, especially with type 2 diabetes, that yes, we know that there is an increased risk in persons who are obese and have a family history. But we usually look for that onset in the 40s and 50s, maybe late 30s. But now we're seeing children. So, and I call them children because they're less than 18. So we're seeing younger children, persons in their 20s as well, presenting with type 2 diabetes, which we would never have expected to see for them. And I guess it's because we have that next pandemic of obesity that is forever emerging and evolving, and poor eating habits, and even the lifestyle factors. And for me, that's very concerning because when we look at these conditions, and we mentioned a lot of things like heart disease, kidney disease, in 20, 30 years, when we have a population of persons who in their 20s and 30s already have been diagnosed with these conditions, when in the prime of their lives, living, having their families, enjoying family life, working, earning, and governments in the Caribbean are very focused and concerned now about our national insurance schemes and so on. We are going to have a generation of persons who have these comorbidities or complications long before we would have expected or anticipated that they would have them. And therefore, then instead of being able to work and earn and support their families, they're now the sick person. So there's a breadwinner that's lost from a home. Who is going to send that young person to school, even if they wanted to aspire to go to university? Who helps that the younger child in that family? The older ones now who should be retiring and enjoying retirement, they now have to worry about how well they're going to be able to help the little ones coming up and still look after the sick ones in between. So that's something that is very concerning for me as a primary care physician, and something that I think that we all need to pay attention to in this season that we're in as it relates to these chronic diseases. We know that there are many bumps and roadblocks for persons as they manage their conditions, and you would have highlighted some of them. So, for example, lack of family support. I've met patients before who would have said, well, I have to cook 2 pots because the others in the house are not going to eat. Yes, I see Natisha shaking her head, and I'm sure she hears this from her clients. So they have to cook. Yeah,
something that we always say. And that is exactly what Marsha was saying. And you said the same thing and reiterated it, that the concern is what's happening at home and what care is being given that the numbers are increasing. And are you all hearing me? Because I'm singing and I'm breaking up.
We're hearing you.
Okay, that's important. It's matter how you hear me, not how I hear myself. Yeah. So, one of the things WHO has been pushing is universal health. I for them to see where they are going with this, because as you rightfully said, if we have more and more younger persons even be diagnosed with these conditions, I'm wondering how far will we go with universal health? Because in the system, we know the ratio of health professionals to the population. And when you start talking universal health and then you're combining that with increasing numbers of persons with the condition, I get very concerned about that. I remembered about 10 years ago, just as you said, a 10-year-old boy came to the hospital, and I was shocked. He was diagnosed with high cholesterol. But you're thinking in your mind maybe 230, 250, those sort of manageable numbers. It was 800 and about 56. So, that was 10 years ago. So the concern is now, where are we today? How many other young persons do we have walking around with these types of levels, and they may be unaware of what that is? So part of what I do in terms of my concern and my profession is encourage something strange, encourage parents to take your children to the doctor and get a complete medical done. That's something that they are not used to, but it's something that now, based on our lifestyle, it is necessary.
I absolutely agree. It is. And you mentioned young people, and young people think that they're superheroes, they're
Of
invincible.
course.
Nothing will
Of course.
happen to me. I feel perfectly fine. And the thing is,
Yes.
their bodies are able to withstand so much trauma and insult before it actually starts to
Yes.
break down and show problems. So
That's
we
right.
really have a challenge on our hands. But that brings us to the next section that we want to go into. And I want to start with you with this section, Letitia, because we know that food is intimately related to the culture, not just in Trinidad and Tobago, but across the Caribbean. And we like our food. So, as a registered dietitian, how do you advise your clients and your patients to approach their meal times?
So I'm going to take this opportunity because I know if there are any dietitians that are here with us, they would be sitting back to hear her promote the profession. But it's inevitable. It has to be done in order for us to appreciate what we do as dietitians to help the patients. So it's not, a one size fit all. It is not. And that is the first thing people need to understand, that it's not a matter of me calling me and saying you need a meal plan for somebody with diabetes. Now, that's not a strange call for me or any other dietitian. Oftentimes, people would call you because they're looking for help, they're looking for information, as we started off talking about. So they ask in genuine concern. But it cannot be that I just have something that I can just print off and just give to every single person if I want you as an individual to get proper care. So there are things that we have to take in consideration. Even something as simple as time. So what people do not understand, and they will tonight, they will understand that as dietitians, we have to look at what you eat, how often you eat it, the amount that you eat, your usual times for eating, the medications that you take, the times you take your medication, the amount of medication that you take. We have to take into consideration your lifestyle. Do you have a sedentary lifestyle? Do you exercise? What time do you exercise? What kind of exercise do you do? How long do you exercise for? We have to take into consideration your role at work. What do you do? Are you mobile on work? Are you more in the office? Who do you have to interact with? When you go home, what do you do when you get home? What are your responsibilities? So you see, a dietitian really has to get into your life. You really have to have that relationship, because all of that information is used to calculate what your meal plan is and what time you should have the meal. Because in practicality, why would I recommend you to have breakfast at 6 a.m. when I know very well that at 4 a.m. you are up, and at 6 a.m. is when you're on journey or en route to work? What am I going to say then? That would be wise. So for me to say to you, you must have breakfast at 6 a.m., it's not practical. If I know that you have a very busy lifestyle and you're on work, you are in high demand, would it be practical for me to tell you then that every 2.5 hours you need to have something to eat? And then my recommendations are things like provision and some sort of steamed fish or vegetables. And I know those things may require a lot of time to prepare. And I'm suggesting these things during the day. So you have to be practical in even a recommendation. So we try to keep meals generally for persons based on the kind of condition that they have and all of this. So you find for persons with diabetes, they may tend to have recommendations like 3 hours. We may not go beyond that for the reason of maybe the medications that they're taking. But at the end of the day, it still boils down to each individual, what they are doing, how they are doing it, to make sure that whatever we recommend is practical, it's easy to follow. And even though we have a culture that determines what you eat when you eat it, because there is no way, for instance, Diwali is coming up, There's no way you're going to give anybody any Sunday lunch type of meal with macaroni pie and all this on Diwali. I don't think even I would eat that because it's Diwali. So even in a culture-based environment where I know the influence is very strong, we still have to guide you accordingly. So if we know one meal is a culture-based meal, so for example, sada roti with any sort of vegetable, that's a culture-based meal rather than nutritionally balanced, then we know, look, this meal is culture-based, but then as a dietitian, you put those nutrients lost from that meal into some other form of the meal for the rest of the day. So the nutrients is lost. So that's our oversight into meal planning and diet and how we usually try to manage it.
Great. And I hope that persons take home from that as well too, that there's no one size fit all and that it really has to be personalized based on you as an individual, your demands, whether that is your work demands, your home demands, and your individualized conditions. And that is not a quick fix and we slap on a plaster and we go our way.
Definitely not.
Great. But and still in keeping with, managing NCDs and how we approach living with them, people oftentimes, Rayan, when they hear the term medical social worker, they automatically think that they're being sent to get welfare services. And I know that you are very passionate about this. So please explain your role as a medical social worker as it relates to chronic diseases. And I know you will expound and give us examples.
Okay. Thanks again, Sandy. So medical social workers are under the umbrella of welfare services. We are all, as healthcare providers, interested in the well-being of our patients. When we hear the term welfare, we often think of grants that are provided to provide income support. And whilst there is a role for that, because when our patients become ill and they're incapacitated from earning, they have lost earnings, or they might be unable to provide for their families, there is a role for the welfare department, which is under the Ministry of the Social Development and Family Services, to provide that kind of support. However, medical social workers, recognizing that need, will refer clients to various agencies in the community where they can benefit from financial and material resources. Unfortunately for us, we as medical social workers do much more than network clients to agencies in the community for material and financial services. Medical social workers, in dealing with our patients who present with non-communicable diseases, present a host of issues and challenges that they face in coping and with living with their conditions. Medical social workers establish rapport with our patients and family members. We are concerned about the entire unit, all their significant others, helping each member of the household, as much as the child as well in the household, to understand how their family member, who is the patient, is impacted and how their roles are going to be impacted, as well as what they need to do to provide support so that everybody in the family is able to adjust to what is happening to this particular patient, whatever the condition may be, whether it be with if the patient may have had a stroke, or the patient may need to engage in some kind of treatment, for example, with our end-of-stage renal patients who need to undergo dialysis. There are many life changes that need to take place in not only the patient's lives, but also in the lives of those family members who are impacted by this individual who is experiencing illness. Dealing with family members is always crucial in our interventions, because if there is very little support, that is going to impact the quality of care that this patient is going to receive and their ability to cope. They experience lots of issues even within navigating in the healthcare system. As we know, there are long waits at clinics. If you do not have someone to come with you and provide that support for persons who need it, then that client may find themselves missing their clinic appointments, unable to be monitored adequately, etc. Also, there are also delays in accessing services. If they have their tests to do and stuff within the hospital system, we do not have our agents, etc. clients do experience issues, and many times they present in the clinic as being non-compliant, etc. Those clients are in fact referred to the medical social worker, and we will have to help that client navigate, access services, network with resources out in the community, advocate for our patients who need to have their issues highlighted by the doctors or known by the other members of the medical team. We are advocates for our patients. We fill the gap so that where they themselves cannot do for them, reach out to the other members of the team and help the other members of the team understand what the patient is going through. The medical social worker performs that role in helping other providers within the team understand what is happening in this patient's situation. Very, very important to us as medical social worker is understanding the person in the environment, because every single, just as Natisha said, there's no one fit for all. We do focus on each client's individual's needs and what their support systems are. And as of course, provide counseling and support that is needed for them to cope better and live with their conditions.
Thank you so much for sharing that. And I do hope that our listeners gleaned a bit from what you would have said just now. Marsha, what about you? What have you found useful for your clients and patients in your role as an educator?
Yes, hearing me right?
Yes.
What I would find useful is a holistic approach when it comes to dealing with clients with chronic diseases. Specifically at our department, reassurance is important. They may need guidance in terms of what other services are available, in terms of social worker, dietitian, because some of them don't have all the resources available that they know of, but it is available. So we reassure them and we also guide them in the right direction in terms of how they could access those additional services.
Okay, so we really see how all of the different services and arms work together to ensure that persons are empowered to be able to live with a chronic disease. Because I think that oftentimes persons think that their lives are over when they get that diagnosis of a chronic disease. It's just like, there's nothing left for me in life. And we have a lot of persons and a lot of even healthcare providers who are actively living life well with their chronic disease and making an impact on others as they go through their day-to-day activities. I just want to pause, remind those who are in our audience that you can type your questions into the chat room and we will answer them for you. So just a reminder before, if there are any questions, make sure that you type them in because we want to be able to address your specific concerns today. Now, there's a special topic that we just want to talk about as we're coming into the last segment of our conversation this afternoon. And I think, patients and healthcare providers are often recognized and remembered when we talk about chronic diseases. I think everybody would agree with that. But we have some unsung heroes who are very closely related to these persons living with the chronic disease, and oftentimes unintentionally, because it's not intentionally, but unintentionally, they're overlooked. And I'm talking about the caregiver. We have some amazing caregivers out there. Someone just mentioned persons who have to undergo dialysis treatments. And that is intensive because, especially when you're on hemodialysis 3 times a week, and a center is not just down the road from you, but you have to be driven to that center. Sometimes that center may be 30 kilometers away or more. And that's a 3 times a week thing you have to do. You have to sit there, wait for that person to finish, or try run some errands while they're on the machine, and then come back quickly to facilitate them, to pick them up, carry them home. And then apart from doing the dialysis runs, you may have to do other things for them, just for them to be able to get by day to day. And we just wanted to highlight caregivers at this time because we do understand and we recognize that they face a tremendous burden and they too suffer from burnout. Is actually a term that is defined where they are exhausted, they're tired, they still push, but they're not coping, they're just going through the emotions. And oftentimes they themselves, sometimes they may have a chronic illness, or they have a chronic illness but they don't know because it's undiagnosed, because they don't find any time to go to a
Right.
healthcare provider for themselves. So that is something that I want us to, I just want to hear your thoughts on that topic at this point in time, and then also share a little advice for those persons out there who may be caring for someone with a chronic illness. So we will start with Rayanne and then Miss Lambert, and then we'll end off with Marcia.
All right, I would have touched on this a little bit in my last opportunity to share with you. We as medical social workers see oftentimes caregivers being not only neglected, but not enough attention is given to them within the health system. I remember trying to develop some initiatives out in the community when I was in Victoria many years ago. We actually developed support groups for caregivers and would have, especially for persons taking care of persons with non-communicable diseases, particularly strokes. And because, of course, these persons, as you say rightly, they are relatives of these patients and they feel they have a responsibility to care for. And we would want them to care for because they are the best persons to care for patients, but they need support. And persons going through similar situations like themselves, there's something called mutual support where that you can gain that support from each other, having shared similar experiences. There's nothing more powerful than that we have seen. And more and more as healthcare providers, we need to integrate our caregivers in our clinics so that we can recognize them, we can see them, we can give them the opportunity to care for themselves in terms of from a medical point of view. As you say very rightly, many of them become ill, having neglected their own health concerns because they are so caught up caring for those persons who may be bedridden or have, as you said, dialysis is very, very challenging for caregivers who have to ensure that patients obtain their dialysis treatments, etc., and many other illnesses that caregivers are required in terms of caring for their loved ones. Um, Medical social workers in encountering these kinds of situations do encourage patients to obtain support. So work out some kind of rostering, sharing the responsibilities, identifying other significant others within the family. We actually assist calling in if they can afford to have paid help when it is needed. If you are responsible for doing the caregiving, at least somebody could do the cooking and the cleaning so that everything is not on your shoulders. Stress is very much associated with the amount, as you say, burnout. They do experience some burnout, and I myself, as would have cared for my father with the help of my mom, and did experience some degree of burnout, and we had to take time out. We had to share. We had to actually roster times, and I know there is benefit in approaching caregiving in that way. So I just want to advise caregivers to look for the support, identify ways in which you can get the help that you need, ask for help. Many times we do not ask for help. Even though the extended family is not as existent as it was in the past, and most of us are working because there is need to put meals on the table and provide for the needs of our families. You find that extended system that we had years gone by is not as vibrant, is not as existent as was before, and that too has placed burdens on families. You find many persons, sometimes when patients come into hospital, we receive those referrals where relatives are saying we cannot do it anymore. We cannot take our patients home. We cannot take our loved ones home and leave these patients, much to the grief both to them and to their patients because they are unable to do it and they are unable to afford paid care. And many of our patients remain in hospital. For us as medical social workers to find alternative residential care settings, which is always not always available or affordable to family members. So there are a number of factors, a number of issues with regard to caregiving, and in our country, we need to look at how we can have rehabilitation, transition facilities in order to support patients and caregivers. So even if we want to get a little time out, we are able to know that we can place our relatives somewhere for a short time so that we can get that support that we need so we can care for ourselves and our families as well. All right, so I just want to share that and also to make a plug for us as a healthcare system to look into providing those kinds of support for persons who need it.
Agreed.
So I just want to, go straight in the same context as Ms. Sammy presented. For healthcare, the care providers to ask a question. Many times they may find themselves as they are overburdened mentally trying to do so many things, as Ms. Sammy would have highlighted, that they don't ask. Ask a question. You are not sure, ask. In terms of nutrition and dietetics, you're not sure if the person should be eating this, you're not sure of their diet, ask. Ask the professional. And that is something that is absolutely critical. Now, I do have, a savior for that, and I can say that help is on its way, but we know that help is on its way doesn't mean it's going to be here soon, but it's on its way. Because the World Health Organization has developed guidelines for self-care, and it is trying to help us as a health institution to be able to help the care providers by giving them the tools that they need to help the patients at home. They are not trying to make them become us as health professionals, but trying to make their jobs easier. So for example, even as an RHA, we are working on one of our own applications that can be given to patients so that they can use it on their mobile devices. So that you find they have on this mobile device access to all of the health professionals that can help them in their care. And this will certainly help the caregivers. So they may find it the journey to the clinics, to the institutions, and just having to get there, get a parking, having to pack just to get breakfast and so on the way. All of that adds to trauma, to mental burden. So you find that when we introduce these kinds of systems, it helps the caregivers. You find when they are able to ask and they get the confidence simply, like for instance, in nutrition and dietetics, if you come with someone and you mention to the dietitian your own challenges, you can be given advice. You can be guided so that you would be told, look, this is what clinic do you go to? When you go there, you can ask for a referral, we can access them, we can also help you. So when you come bringing your patient, you yourself can also get attention. So there are avenues in which we can help them, bearing in mind that even as dietitians, we don't work alone, just as it was mentioned with MSW, medical social workers. We also have to collaborate with all of the other health professionals in order to help them and guide them. And that also helps to help the caregiver, because sometimes they have referrals to other areas. They may be having challenges with other aspects of the healthcare system. And we as providers, we can go an extra mile. It may take a little more, it may take an extra effort to make another phone call to find out from your coworker, how can I help this person? How can I guide them? Because we are mindful, as Ms. Sami highlighted, that they do come with a lot of mental stress of trying to care for this person and still care for themselves. And we started off this entire meeting discussing the types of diseases that they are. And one of it was mental health. So if we can help the person, it eases up, because we know that if it's not managed in the long term, they're going to have other health problems. So for us as dietitians, we try to approach, just as it was highlighted with Marsha as well, the holistic approach to care, recognizing that this person is caring for someone and somebody needs to care for them as well.
Thank you. And Marsha?
Right. So to add to what the other young ladies would have spoken about previously. What we usually do at our department, we invite the caregivers to come along to the sessions so that they could express whatever challenges or concerns they may have in assisting the patient or client with, with whichever chronic disease that they may have. Now, as well, we would have mentioned before that sometimes the caregivers, we would have identified that they sometimes have chronic diseases that they don't even know about. So if that is identified, we also would give them some type of referral to see whether it be the doctor, if needs be. Because it is a challenge trying to manage everyday living and to have to take care of this client or to assist them in managing their condition. So it is challenging for them, and we identify that and we try as much as we could to hear out the caregiver and try and assist whatever way that we can, whether it be just sometimes they just need someone to talk to, you know, and they may also need some, clarification as to how to assist the client to manage better going forward. So I think that is an important aspect as well.
Okay, great. So that we're rounding up our discussion for this evening, and we've spoken a lot about chronic diseases today. We would have identified some of the common conditions, challenges that persons may have in managing these conditions, as well as, actually living your life with this chronic disease, knowing that is not the end of the world. And also mentioning those unsung heroes of the caregivers. So as we tie up this evening, what we want to remind you as healthcare professionals, and I'm putting back on my primary care physician hat now, is that you do not know if you don't check oftentimes with chronic illnesses. So there are what we call silent killer diseases. Unfortunately, the top 3 things that cause death here are in those, can be classified as those. So that's hypertension, diabetes, and heart disease. And when we say about silent killer diseases, oftentimes your body has already started to get damaged by the time you are diagnosed. If you're becoming symptomatic, then more often than not, there's already some kind of damage to your, what we call your target organs from these chronic diseases. Why? Because persons can walk around quite comfortably with a blood pressure of 200 over 110 and feel perfectly normal and have absolutely nothing. But just because you're feeling well, and the thing is, the body learns to adapt to these abnormal states. Even though you feel well, things are still happening on the inside. So you're getting changes to your blood vessels, you're getting changes to your heart muscles, you're getting changes and damages to these arteries that supply the kidneys and so on. So that by the time sometimes persons are presenting with their diagnosis of hypertension for the first time, sometimes that's when they present with a stroke or a heart attack. Or by the time we start to do blood tests for them, we realize, but you know what? We're seeing some changes and some damage to your kidneys already. So we want to encourage you this evening. Know your numbers. There's an initiative started in 2011, I think it was. Check yourself, know your numbers, by the then Minister of Health, Minister Khan. And simply what it meant was, when you feel well, whether you feel unwell, at least once a year, go see your physician, your family doctor, your primary care doctor, your GP, and get simple basic things done, like a blood pressure measurement, a blood sugar measurement, cholesterol checks. We also encourage persons of the appropriate ages to ensure that they do the screening that they need to do for the cancers appropriately. That includes things like your pap smears. For men, that's the digital rectal examinations, your prostate checks, breast examinations. Because what we have seen and what we have found is that when we can detect things earlier, whether it is a cancer or something like diabetes or hypertension, we can manage, we can control, we can prevent, we can delay the onset of complications. So that instead of having to worry that now you have hypertension and you can't walk well now because you had a massive stroke, maybe we'll just have to worry about you living with your hypertension but managing it well, so that you have the best possible quality of life for yourself and by extension your family. Because when you are unwell, it has a significant impact on those who are close to you. especially when the breadwinner of a household becomes unwell and sometimes stops earning. Then what happens to that family? So we thank you all for joining in this afternoon. I am not seeing any questions, unfortunately, and that is so unfortunate. But that probably means that we were either as clear as crystal, or maybe we were just clear as mud and we had you so confused you have to go and look everything over again. Hopefully, it is the first one, and we are happy that we could have shared with you this evening. Sincere thanks to our panel members this evening who joined in. And we do hope that something you learned here today, you can take that with back to your families, back into your communities, and you can share and encourage others to one, early detection, get yourself checked. Two, life is not over. You can manage. There is light at the end of the tunnel. You can still have a good quality of life. And three, that together, through that collective power, we can do better overall. Be reminded that this program, in case you want to let someone join in and share with it, it's going to be available on the Southwest Regional Health Authority's YouTube page. And please listen out for when we have another forum like this for you. We have them every last Tuesday of the month right here on Microsoft Teams. You can go and you can have a look back at the other ones that we have done so far, starting from April and come forward. So we have one question that just popped in. Well, another one too. Lily is saying, good night, I came in late. Is the pain behind the neck related to high blood pressure? So Lily, that's an excellent question, because that's something that we oftentimes hear in, and persons usually ask us that. And when you came in, because I saw when you came in, what we were just saying is that oftentimes hypertension doesn't really have many symptoms. Some persons may experience early morning headaches. Some people may even get nosebleeds. But oftentimes when we correlate it is not a pain in the back of the neck. Not saying that that can't happen, but that's not something that we commonly see. I hope that answers your question. And then for Merlin, they're just acknowledging that yes, there's a question. They're talking about psychological care. I'm not quite sure what you're trying to ask, Merlin. You want to know how to access the psychological care, or how you can access it? If it is that you want to know how to access it, we have several options in Southwest where you can get psychosocial or psychological counseling, but it starts with a visit to your local health center. Then you can be either referred to your medical social worker or one of our mental health services where you can get the necessary help. And Jason is saying, with regards to diabetes, I've read that diet and exercise can reverse early stages of diabetes. In your professional experience, how realistic is this information? Right. So for Jason's question, diet and exercise can reverse. I wouldn't, when you say early stages, I am not quite sure if you mean diabetes as now starting, or you're talking about pre-diabetes. Right, you just defined it. So yes, with persons who have pre-diabetes, one of three things can happen. One, you can revert back to normal glycemic control. Two, you can stay in that pre-diabetic phase. Or three, you can progress to full-blown diabetes. There are things that we can do in terms of the diet and exercise that does help. And there are some persons we also would include something, for example, like metformin. And with that addition, there are some persons that we see, and I've seen it myself, they have reverted back to normal glycemic control. But what we do encourage is that they have to continue the lifestyle measures that they would have implemented. I hope that answers your question. And for Merlin was just saying, yes, there is care. Is there this care for those with NCD? So yes, there is this care, the psychosocial care and so on for persons with NCDs. And as I said, I told you how we can access it. You can go through your primary healthcare clinics or your local health centers, or what you know with your health centers. Joel, I'm not sure if he's still here. I think he left, but he had asked a question earlier. If I am pre-diabetic, what food should I make sure to increase in my diet? So I'm going to hand over that question to our nutrition and dietetic specialist. Just give me 2 seconds.
Sure, as we discussed before in terms of diet, once a doctor has identified that you are pre-diabetic, they should or you can ask for referral to a dietitian so that you can have your entire diet assessed as to determine what we may need to change. I mean, on a general basis, you would always hear us try to encourage the use of vegetables. We try to encourage the use of the provisions, and it has to do with in terms of looking at your overall diet where we could increase some fiber. So just as a takeaway, you can visualize a plate, a eating plate that you would have at home. You try to imagine half of that plate is vegetables. Then the other quarter of your plate, you can put complex carbohydrates, so we can put some provisions there. And the other quarter of your plate, you can put your protein source. You can put your peas and beans or your food from animals. So that is your overall logistics of looking at how a person's plate should be. It doesn't mean that you cannot have rice, but when you have rice, you would not, still want to stay in that quarter of your plate. You would not want to have Trini style, which is we fill the entire plate first. We create a foundation like we're building a house with rice, and then we place everything on top of that. That is not what we want to encourage. So just following the logistics of eating that plate would help you in terms of guiding you in terms of the diet. But the specifics of it, you would need to visit your friendly neighborhood dietitian.
Thank you very much. And there's another one coming for you. This is Theodore T. Says, my concern is diet regimes that may be preventative. Are there programs or initiatives for limiting onset of NCDs?
Right. So when we're talking about the diet again, I'm going to put out the SWRHA number out there, which is our 225 HEAL, the extension 1505. That is the dietitian's extension. One of our clinics. We also have a dietitian available at every health pharmacy because you would need a closer guidance as to what can be done. As Dr. Arthur would have emphasized, there are foods and diets and regimes that we can put to help along with the guidelines from your doctors so that it can reverse where you are at, but it also depends on where you are at. But we really try to work with maintain. Once you've established your values at a healthy level, we really try to keep them there, because as long as you revert to your lifestyle choices prior to the guidelines, you may find that you may start back developing symptoms and then become fully diagnosed with whatever is the NCD that we have been trying to manage.
Thank you very, very, very much. Merlin had a comment earlier, and I think we did address it. It was about psychological support for persons with NCDs. So that's one I had missed earlier, but we did cover it. I'm just double checking to make sure we don't have any more questions in the chat, and I'm not seeing any more at this time. But I must commend you, y'all had some excellent questions and comments and observations, and that's what we want. We like you to stimulate conversation and let us address those concerns. Our nutrition and dietetic expert mentioned a number there, 225 HEAL, or it's 225-4325. That's what it translates to. And then when you get the PBX, you can then type in the extension that she would have given, 1505, if I remember correctly.
Correct.
Good.
Yes.
Great. So you got two numbers tonight, right? So 225-4325 extension 1505, and you would have also been given the number for the customer care line, which is 87 SWRHA or 8779742. So that brings us to the end of this program this evening. Once again, thank you very much for joining in. Continue to follow us on our Facebook and Twitter handles, Instagram handles. I hope I got it right. The Corpcom team will have my neck for not knowing properly. But continue to follow us on our social media handles so that you can get more information as to when we have other programs. We generally, oftentimes, are in a community close to you. So look out for us. We are happy and we stand willing and ready to help address your concerns and your health needs. Have a good night, everyone.